Dr. Wieck, over to you.
Thank you very much. I should like to thank EMA for giving me the opportunity to speak at this important hearing, but I also feel very privileged today to hear about the account of mothers of affected children. I'm a consultant psychiatrist practicing in Manchester, and I'm also a specialist for mental disorders in pregnancy and the postpartum period. I'm also the chair of the Women's Mental Health section of the European Psychiatric Association, and I'm attending here at the behalf of this organization, but also of my local mental health trust. Returning to question 1 about the risks arising from valproate, I agree with what previous speakers have said, and I would like to add maybe also that it is likely that the harmful effects of valproate operate not just in the first trimester, but for the whole of pregnancy. These findings are largely based on studies of women with epilepsy, but there is little evidence that they do not also apply to women with other disorders. What is also of concern is safe doses for the different types of harm have not been sufficiently identified, and it needs to be kept also in mind that the relationship between the valproate dose and the concentration in circulating blood is very different between individuals. We've also learned from research evidence that prescribing a high dose of folate together with valproate is unlikely to prevent harm in many, if not most, children. In regard to question 2 concerning measures which have already been adopted, I would like to first say a little bit about the use of valproate in mental health. Valproate has a place in the treatment of bipolar disorder. It is licensed in the UK for the treatment of acute mania, and if the patient has responded, it can be continued in order to prevent further manic episodes. In clinical practice, valproate is also used for unlicensed indications. The 2 current bipolar guidelines by NICE, the National Institute for Care Excellence, and the British Association for Psychopharmacology include a range of other medicines. In these guidelines, valproate is now not regarded as a first-line treatment for bipolar disorder any longer, but rather it is recommended if the first-line treatment is not sufficiently effective. There are a number of alternative treatments to valproate that could be used if first-line treatments fail. In my view, it is important to consider the use of valproate for mental disorders separately from its use in neurology, where the benefit-risk ratio is likely to be different. So my answer to the second and third question will therefore only cover mental disorders. Now, looking at how commonly valproate is prescribed to women of childbearing age who have a bipolar disorder, 2 recent studies, there is not much evidence, but 2 recent studies have suggested that it may be as many as 34% in primary care of all women who have bipolar disorder and are of childbearing potential, and almost 10% in women who are under a mental health trust. In recent years, there have been several surveys, mostly in the UK, of valproate prescribing practice in mental health, and we've conducted our own series of audits in Manchester. Despite the measures introduced by EMA and the MHRA in the UK, and our own local training and education efforts for local prescribers, we have found in our last survey in Manchester from November last year that still less than half of women prescribed valproate are informed by clinicians about the risks of valproate in pregnancy or are asked about the use of contraception. And this is similar to the findings of a recent large national survey here in this country of 55 mental health trusts, which was also recently published. In my view, the recent UK MHRA patient safety alert from April this year is an important step forward, trying to ensure that health professionals inform all girls and women of childbearing age and restricting the use to when there is no other alternative. My experience is that in my local area, our Mental Health Trust and the Medicines Management Committee are taking the suggested actions. So hopefully that will translate into much improved practice. However, in my view, EMA or the MHRA should explore whether we can go further to reduce the risk of harm in unborn children in the case of mothers who have a mental disorder. As you are probably aware, the NICE guidelines for England and Wales state that valproate should not be offered to women who have a mental health problem and who are pregnant, are of childbearing potential, or who are planning a pregnancy. These stronger restrictions by NICE are, of course, operating in England and Wales, and not necessarily in other European countries. In addition, in this country, NICE only offers a guidance, which does not have to be followed, and there can be many exceptions to this, and it is often not followed by clinicians to a large extent. So the question arises whether this NICE guidance should be perhaps adopted by the European Medicines Agency. Unfortunately, there is not yet convincing research evidence whether there are clinical situations which cannot be managed without valproate in bipolar disorder. There are certainly strong opinions on both sides. There are, for example, consultants working in psychiatric intensive care units who say they would not be able to treat women with severe mania without valproate, and others who say they have never used it in women with acute mania. There are also strong opinions amongst other colleagues. Because of this, I would suggest that a clinical panel is convened that looks at these questions more in detail and examines it closely and formulates an expert opinion on the benefit-risk ratio of valproate in bipolar disorder for women who are pregnant or who plan a pregnancy or are of childbearing potential. I think that this panel should include perinatal psychiatrists, experts in bipolar disorder, but also experts on contraception, and last not least, women who suffer from bipolar disorder themselves. I think it would also be helpful for prescribers to develop specific guidance about issues that clinicians are often uncertain about. And we are often asked as perinatal psychiatrists about these issues, such as, for example, and this has been mentioned before by a previous speaker, how quickly can valproate be withdrawn in pregnant women? This is an important question because we know that withdrawal of mood stabilizers in bipolar patients can precipitate manic illnesses. Another question would be important to look at that are what are the sequential treatment options for bipolar disorder without valproate or even with valproate? And lastly, what is the best approach to highly reliable contraception? Thank you very much.
Well, thank you very much indeed for that very thorough and clear presentation, helping us to focus on the issues around bipolar and use of valproate in women.